monthly online classrooms. It is my honor to welcome Dr. V.K. Shashidharan Sir, the Emeritus Professor of Department of Family Medicine, Government Medical College, Kozhikode. It is my honor to welcome him because he has been also one of the key inspirations why I chose my career in family medicine. I also welcome Dr. Arifa Rahman, who is presenting the case, doing the case presentation today. It's overwhelming to see the academic activities of the residents, and I hope this session is going to be enriched with a lot of interactive discussions. Once again, welcome all of you. Over to you, sir.
Thank you. Good evening, all. I thank you all for inviting me because I was having severe sinusitis and bronchitis and took antihistamine and I'm feeling sleepy. So I hope I will not do bad. Let us see. Request Dr. Arifa to start and we will discuss as we do at bedside.
Okay. Good evening, all. Am I audible?
Yeah.
Yes, doctor.
Good evening, all. I'm presenting the case of Akash, a 26-year-old male. He is an electrician. He is a native of Kapat, Calicut, and now residing in Guruvayur for past 8 months. The history is given by himself and it found reliable. His presenting complaints was fever and headache of 3 weeks duration. And the history of present illness. The patient was in his usual state of health 3 weeks back, and he had developed a low-grade fever. And the fever was more towards the evening time and was not getting relieved on taking any medications, mainly like paracetamol. And along with fever, he also had complaints of headache, which was insidious in onset, gradually progressing in nature and worsening towards the evening hours of the day. That is, along with the fever. And it was a bifrontal headache, which was throbbing in character, and headache was getting relieved after sleep. And not associated with nausea, vomiting, photophobia, phonophobia, blurred vision, or retroorbital pain. And there is no history of cough, nasal discharge, breathing difficulty, chest pain, or sore throat. There is no history of dysuria, altered urine stream, increased frequency of urination, decreased urine output, or facial puffiness. No history of myalgia, arthralgia, yellowish discoloration of eyes and urine, no anorexia or aversion to food. There is no history of palpitations, dyspnea on exertion, and pedal edema. And with these complaints, he consulted nearby hospital and took medications, that is symptomatic medications, but the symptoms were not getting relieved and was referred to Calicut Medical College for further evaluation. That is after the onset of fever, 7 days after the onset of fever. He was admitted in the hospital and had received antibiotics, oral doxycycline for 5 days, and other symptomatic treatments. The symptoms were somewhat relieved with medications, and he got discharged after 5 days of admission. For the next 3 days, he was symptom-free, but fever and headache recurred after 3 days. He also had multiple episodes of vomiting that day, and it was preceded by nausea, and vomitus contained food particles only. There is no history of greenish vomitus, hematemesis, loose stools, or abdominal pain. He was again brought to the casualty and was admitted again. This admission was towards the end of 2nd week, and during this period, his mother noticed loss of weight as his clothes were getting loose, and around 10 kg of weight loss is present, as he is telling like that. And no history of night sweats, loss of appetite, productive cough, swellings anywhere in the body, and no history of any bleeding manifestations. There is no history of cold or heat intolerance, no history of any constipation. There is no history of any recurrent oral or genital ulcers, photosensitivity, arthralgia, and dry eyes or dry mouth. There is no history of any high-risk sexual behavior, blood transfusions, or substance use. There is no history of exposure to uncooked meat, milk, or any exposure to animals. No history of travel prior to the onset of symptoms. No history of any drug intake, including indigenous medications recently. And no history of skin rashes. No history of exposure to forest areas. And no history of any clustering of cases. During this second admission, he had received IV antibiotics, that is ceftriaxone, for 7 days, and other symptomatic medications. And he is admitted here for past 8 days, and no further episodes of fever and headache is present for past 4 days. Sir, the presenting illness, sir. Sir is not. 1 minute, sir.
I was muted, sorry.
Okay, sir.
So in summary, he had a 26-year-old male who was previously asymptomatic, had fever, low-grade fever of 3 weeks, and bifrontal headache.
Yes, sir.
What possibilities we can think at this stage with fever, headache alone for 3 weeks?
Since the duration of fever is more than 2 weeks, sir, we can think of any chronic infections like tuberculosis,
Any other possibility?
enteric fever.
Don't forget enteric fever, and the fact that he received doxycycline also tells one more thing. What is that? Scrub typhus also. Don't forget scrub typhus also with that history.
Okay, sir.
But there is no GI symptoms, but he had vomiting.
One episode of vomiting.
And what could be the cause for that vomiting?
Maybe gastritis.
Gastritis only. Can it be hepatocellular damage?
Not like no other symptoms.
Why it is not hepatocellular damage? Hope I am audible. Hope I am audible to everyone.
Yes.
Am I audible?
Yes, sir.
So what could be vomiting appears to be gastritis. Why not hepatocellular damage? In a febrile patient, vomiting, you should always consider hepatocellular damage. What is against that?
He is having nausea before the onset of fever, and there is no anorexia.
What is against hepatocellular damage? Anybody else?
No history of any anorexia.
That is it. No history of anorexia. And one more thing, anorexia can still occur in gastritis. One more symptom which tells her it is unlikely to be hepatocellular damage.
No history of any yellowish
Yellowish discoloration or something else. Yellow urine.
yellow urine.
Because if it is hepatocellular damage, even if the patient forgets to notice the yellow color of the eyes, the sclera, they usually give history of yellow urine also. So the symptoms are not in favor of hepatocellular damage. So it is unlikely. Anyway, it is not hepatocellular damage, whatever may be, because you can get hepatocellular damage in some infections like scrub typhus. And whatever may be the infection, you may get hepatocellular damage due to the so-called HLH.
Yes.
And the fever may be prolonged. Initially, to begin with, it may be the common infections, but the fever may be prolonged and you may get hepatocellular damage. And anyway, you have to ask for yellow urine, anorexia also along with the vomiting. So, but it's unlikely. And there is weight loss. So what does it favor now?
Favoring tuberculosis.
You can think of tuberculosis.
Also, any malignancies.
Malignancies also you can consider, provided you get some findings during physical examination. Like what? Which malignancies you will consider, if at all?
Hematological
malignancies, like leukemias.
And also lymphomas.
Lymphoma, especially Hodgkin's lymphomas, you may consider. So if you find any organomegaly, lymphadenopathy, you might even think of a hematological malignancy. Any other third possibility other than infection? Infection.
Disorders, like connective tissue disorders.
You can think of connective tissue disorders also. Being a male, it is less likely, but still you will consider that. And then subsequently, you said the patient responded partially to doxycycline, then responded to ceftriaxone also. Response to doxycycline can occur in what all infections? Scrub typhus. Then?
In the
lepto, is it possible to be?
Duration of fever
It is unlike, it cannot be lepto because of the other symptoms, duration of symptoms. So it's not at all leptospirosis. Unless by chance the patient developed HLH after a lepto infection. So we cannot think of leptospirosis. So if the patient has responded to doxycycline, what possibility you may think of? Scrap typhus you can consider. Sometimes even malaria can partially respond. So you should consider malaria also among the infections. Can you get low-grade fever in malaria?
Can get sometimes.
Sometimes it is possible. So you cannot think of, you should not rule out those infections. And if infections are all ruled out, then only, or if you find some physical findings which support a hematological malignancy or autoimmune disorder during investigation, you should still keep infections as the first possibility. Tuberculosis, how likely it is? Can it be still tuberculosis?
Can be.
Tuberculosis is possible, but you may get miliary tuberculosis. When they come with fever, weight loss, you must still consider miliary tuberculosis. And as you rightly said, now still consuming raw meat or partially cooked meat or drinking unpasteurized milk. You may think of brucellosis also as a differential diagnosis. So you need to consider all infections where the fever can be prolonged. And if all infections are ruled out, then you will think of hematological malignancies which are known to present as fever, provided you get some physical findings. And if even that is ruled out, you may think of connective tissue disorders. So that these kind of thoughts should come to you at the initial presentation itself. And vomiting may be gastritis only. Okay. Now the past history.
Coming to past history, there is no history of similar complaints in the past. His mother gives a history of childhood tuberculosis at his 2 years of age and 3 months of taking treatment for the same. The details are not available. A history of suggestive viral hepatitis is present 4 years back, and he gives a history of taking indigenous medications, that is Ayurvedic medications, for 6 months during that time. There is no history of recurrent infections in the past, no history of diabetes, hypertension, ischemic heart disease, thyroid disease, or surgeries in the past, and no history suggestive of any renal diseases in the past.
Can you think of thyroid disease as a cause in this patient? Rarely.
Thyrotoxicosis.
Thyrotoxicosis or often thyroiditis.
Thyroiditis.
They may present as fever and weight loss. But what symptom is against that?
No other features of thyroid disease.
You may not get other features unless during physical examination. What is against thyroiditis? Weight loss and fever can occur. Thyroiditis can, autoimmune thyroiditis can present like this. What symptom is against, if at all?
Painful.
No, loose stools. They usually have loose stools also. Thyrotoxicosis or thyroiditis with increased thyroid hormone levels, irrespective of the cause, they may have increased frequency of bowel movements, which may be mistakenly diagnosed as irritable bowel syndrome sometimes. So the hyperthyroidism can present as fever and weight loss, but not hypothyroidism. But you said he has constipation.
There is no history of constipation, sir.
No history of diarrhea also.
No, sir.
Okay.
Family history, no history of similar complaints in the family. His mother had a history of thyroid disease and surgery done for the same, possibly MNG. No history of diabetes, hypertension, ischemic heart disease, malignancies, or autoimmune diseases in the family.
Okay. In summary?
So personal history, sleep and appetite is normal, bowel and bladder habits are regular, no history of any addictions. Diet history, his diet is deficient in both animal protein and pulse proteins, and diet is deficient in vegetables and fruits, and water intake is also important.
आप है ना 8-5 मिनट की बात आओ.
Status, lives in Guruvayur in company apartment with 15.
Maria. Please ask others to mute.
Socioeconomic status. He lives in Guruvayur in his company apartment with 15 members for past 8 months.
So
There is 4 bedrooms.
he belongs to which country, which state?
He's a Keralite, sir. His native place is in Calicut. Now, for past 8 months, he is staying in Guruvayur.
Okay, I thought he belongs to some other state. Okay.
There is 4 bedrooms and 3 bathrooms. Overcrowding is present. He uses corporation water for drinking and drinks water after boiling. He and his parents are the earning members in the family. His parents are manual laborers. And he has a BPL card holder, and the expenses in this admission are covered under insurance. The nearest health center is within 1 kilometer from his house of stay.
Okay, the social aspects are he is the only earning member.
He and his parents are the earning members. He is an electrician. His parents are manual laborers.
So there is somebody to take care of the expenses.
Yes.
Okay.
Summary. 26-year-old male with a past history suggestive of childhood tuberculosis, whose diet is grossly deficient in proteins, vegetables, and fruits, and also inadequate water intake, now presented with complaints of low-grade fever and headache of 3 weeks duration, and also weight loss of around 10 kilograms.
So the same possibilities sustain in the absence of other features. And that dietary history points towards what?
There is diet is grossly deficient in B12, proteins, folic acid, and iron also.
Vitamin D also.
Yes.
These deficiencies can predispose to several problems, including infections. Okay. Then
differential diagnosis.
The possibilities you can consider on interpreting history is an infection like tuberculosis, and typical presentation of enteric fever, lymphoreticular, inflammatory disorders, endocrine. These 4 all will sustain. These are the possibilities we considered initially also.
Yes,
but wherever you think of enteric fever, think of scrub typhus also.
Okay.
Okay.
Coming to general examination. Patient is conscious and oriented, moderately built and nourished. Height is 179 centimeter, weight is 65 kilogram, BMI is 20. Clubbing is present. There is no pallor, icterus.
Now, let us stop for a moment. In a patient like this, when you find clubbing, how do you interpret it in this context? What are the possibilities when a patient with a 3 weeks history of undiagnosed fever, you on examination you find clubbing? What are the possibilities? You thought of some possibilities.
Infective.
You can think of subacute endocarditis. Subacute endocarditis sometimes can fool you. Among the infections, you will not think of endocarditis till you get some physical findings or cardiac findings. Unless they give a history of previous presence of a cardiac problem like valvular heart disease. So in the absence of that, during the initial interpretation history, you may not think of endocarditis, but now at this stage you can think of subacute endocarditis. Any other possibility? Where else you can get clubbing in a febrile patient?
Lung disease, suppuratory lung disease.
Suppuratory lung disease would have got what? Cough and expectoration. So it is in the absence you will not consider suppuratory lung disease unless you have an empyema. Suppose on examination you find an empyema, it can so for example during physical examination you find features of pleural effusion on one side, that could be an empyema. Suppuratory lung disease, the only possibility is pleural disease. Pinna. Any other possibility?
The patient is having underlying liver.
Liver disease. Patient could be having a chronic liver disease. In the background, all the chronic liver disease and chronic active hepatitis could be of autoimmune etiology. So chronic liver disease you have to consider at this stage. Interstitial lung disease you can consider provided you find what?
Any findings in the chest.
What findings in the chest?
Crepitations.
No, crepitations if you get bilaterally. Anything else?
And reduced chest expansion.
Reduced chest expansion. Very good. reduced chest expansion. So these two, if are present, you can think of interstitial lung disease as a cause. They can also present with fever. Okay, then there was no lymphadenopathy.
No pallor, icterus, cyanosis, or lymphadenopathy. Dry and lusterless skin. Nectar hyperpigmentation is present, and palmar crease hyperpigmentation is also present. Hair is dry and lusterless, and also balding is present. In oral cavity examination, good oral hygiene, no dental caries is present. Glossitis, cheilitis, and stomatitis is present. He is clinically euthyroid, no palpable thyroid swellings are present. Vitals examination.
How do you decide on clinically euthyroid state?
There is no features of any.
What all features did you look for? Sometimes prolonged fevers can be a manifestation of hyperthyroidism or thyroiditis, autoimmune thyroiditis. The same patient can have autoimmune hepatitis also. So how did you say he is euthyroid? What findings help you?
There is no edematous skin or in overlying.
Hyperthyroidism.
On vitals, they can have type.
What physical findings can suggest hyperthyroidism in a suspected thyroiditis?
There is no tremors.
Tremor may be there. One is tremor, pinna.
Tenderness.
Palpitation. Or tachycardia, unexplained tachycardia. Unexplained tachycardia should think of thyroiditis. Or if there is pain over the thyroid. Okay. Or swelling, thyroid swelling with a bruise. And other signs of hyperthyroidism which are rare. But we are considering if at all thyroiditis. Go on. Clinically, euthyroid is very important because thyroid may not be enlarged in some patients with the thyroiditis. But tenderness is usually found in thyroiditis. Okay, then.
Vitals, pulse rate is 84 per minute, normal rate, rhythm, volume and character, no radial or radiofemoral delay. Blood pressure is 130 bar 80 millimeter mercury, right arm setting position. Respiratory rate is 14 per minute, regular and abdominothoracic. He was afebrile at the time of examination. Coming to systemic examination. Gastrointestinal system examination.
What is your objective in abdominal examination this patient? What are you looking for? You need to plan. You need to plan your physical examination depending on the possibilities. So what will you look for?
Since our differentials was enteric fever, we can look for any
organomegaly or splenomegaly?
Splenomegaly or hepatomegaly.
Any other possibility? We also thought of chronic liver disease. So what finding will you think of? Will you look for?
Any firm hepatomegaly.
Firm hepatomegaly is a definite evidence of liver involvement. There are other reasons, but usually it indicates chronic liver disease. And along with that, splenomegaly also. You should look for other signs of chronic liver disease going back. Other signs also you can look for now, if there is. Okay.
On inspection, abdomen is not distended, umbilicus central and inverted, no dilated veins, scars, sinuses, no visible mass or pulsations. On palpation, abdomen is soft and non-tender, no guarding or rigidity, no hepatomegaly, no splenomegaly, no palpable mass. On percussion, no shifting dullness, and bowel sounds are heard normally. On cardiovascular system examination, blood pressure and pulse rate already mentioned.
Again, what is your objective in cardiovascular examination this patient?
Subacute in.
So you look for murmurs.
Murmurs.
Murmurs. Okay.
Shape of chest appears normal. JVP is not elevated. No visible pulsations, scars or dilated veins. On palpation, apex beat is palpable at fifth left intercostal space, 1 centimeter medial to mid-clavicular line. And on auscultation, S1 and S2 is heard normally. No murmurs are there. And on respiratory system examination, respiratory rate is 14 per minute. Inspection, visible part of upper respiratory tract appears normal. Shape of chest appears normal. Trachea appears central. And movement of chest is equal on both sides. No visible scars, sinuses, or dilated.
Equal is not enough. Adequate also.
Equal and adequate.
Okay.
Palpation, trachea central, chest expansion is 4 centimeter, no chest wall tenderness. And on percussion, resonant note is heard over all lung areas. And on auscultation, normal vesicular breath sounds are heard in all lung areas. No crepitations or ronchi is heard.
Okay.
Nervous system examination, higher mental functions are normal. Cranial nerves examination also normal. Sensory and motor system examination normal. There is no incoordination of movements and no signs of any meningeal irritation. Musculoskeletal examination, skull and spine are so normal. Gait is normal and limbs are also normal.
Okay.
Investigations.
So again, you will at this point, how will you modify the original possibilities? You got 4 possibilities based on summary of a history. Now, with the physical findings, how will you modify it?
Again, possibility will be chronic infections like tuberculosis can be
But, tuberculosis will not produce clubbing.
Okay.
Unless that clubbing is a congenital clubbing. That you have to find out from the patient. If that clubbing is not related to the present problem, if you are sure of that from a history says that he has been having it from birth onwards, you can think of a congenital clubbing. In that case, you can think of tuberculosis. Otherwise, now with the clubbing as a part of the problem, you will have to think of other conditions. Tuberculosis will not produce clubbing unless it is a tuberculous empyema. You said chest findings were normal. Empyema would have features of pleural effusion and intercostal tenderness. So there is nothing.
No intercostal tenderness.
Okay. How will you rewrite the possibilities?
Endocarditis.
Subacute endocarditis still you can consider even though murmurs are absent, but you will have to think of autoimmune disorders and chronic liver disease. Chronic liver disease can be due to autoimmune. He is not an alcoholic.
Not alcohol.
So he could be having a chronic liver disease of autoimmune etiology. When you find clubbing, it could be due to a chronic liver disease. But you didn't find any hepatomegaly.
No.
So you still have to consider subacute endocarditis and chronic liver disease. There is no other possibility at this stage. So what investigations you need?
CBC.
ESR.
ESR, LFT.
LFT. Okay, let us see.
Sir, the CBC, sir.
CBC, it shows total count is elevated. And it is polymorphonuclear, no?
No, lymphocyte.
Lymphocyte. They are not helpful. Thrombocyte platelet count is on the lower normal side. ESR.
Yes, sir. ESR is elevated.
Always high. Now you should think of if it is which are the conditions where the ESR is very high, like say more than 100. Conditions where you get a ESR which is very high. Multiple myeloma, more common conditions. Common conditions where you get thyroiditis also, you know, TB, tuberculosis, occult tuberculosis or miliary tuberculosis. But provided that the clubbing is unrelated. Any other? Viral infected endocarditis, autoimmune diseases. So think of all these when you get a very high ESR. So we need to think of all these again. And how do you proceed? Melanosis can be considered provided you get a suppurative focus somewhere. No, do not think of melanosis if there are no features to suggest tuberculosis. Melanosis comes in the differential diagnosis wherever you think of tuberculosis as a cause for prolonged fever. Clinically, tuberculosis seems less likely because of the clubbing. Okay.
RFT.
More important is LFT.
LFT, there is age reversal is present in the
This supports chronic liver disease. And the chronic liver disease can be autoimmune etiology. That is how you have to.
It also is elevated.
When the ALP is elevated, what will you think of? In a patient with this kind of LFT, When you get elevated ILP, what are the possibilities?
Mainly hepatic, any
What hepatic?
hepatitis,
No, not obstructive. Don't think of obstructive. The question is
granulomatous,
about granulomatous hepatitis. Granulomatous hepatitis or infiltrating liver disease. Infiltrating liver disease or vitamin D deficiency, simple. You could be having vitamin D deficiency. That albumin globulin reversal is one thing. Elevated alkaline phosphatase may be simply vitamin D deficiency. You got the dietary history, no? Anyway, we'll consider granulomatous hepatitis, which can be an autoimmune disease. With the granulomatous hepatitis, you have to consider because of the albumin globulin reversal and elevated liver enzymes and elevated alkaline phosphatase. That should come first. Pinna.
RFT and serum electrolytes are normal, sir. CRP
So
also.
what investigations you need at this stage? Ultrasound, I don't think you will get unless you are thinking of suppurative focus. More important is what? Look for ANA profile. Because now you're narrowing down to autoimmune diseases. But anyway, X-ray chest you will need by biliary tuberculosis. But again, biliary tuberculosis is less likely to present with the clubbing as such. So that is unlikely.
ANA profile is negative, sir.
Negative. All are negative.
Yes, sir. Yes, was negative.
Manto test was done.
Manto was done, sir. It's also negative.
And T3, T4?
T3 is 0.86, T4 is 10.1, sir. T3 is TSH is 0.02, sir. It's not visible, I think.
So T3 is low. Low.
Yes, sir.
T4 is?
T4 is high, sir. 10.1.
And TSH is normal.
TSH is 0.02.
It is low.
Yes, sir.
So we have to repeat the thyroid function test. There is something wrong. Because T3, if it is high, it is consistent with the thyroid hormone increase. So you need to repeat the thyroid function. It depends on the lab sometimes. ANA profile was negative. ANA screening only was done. You need ANA profile and you are doubtful. It is not enough. You need ANA profile. Because ANA screening may be negative sometimes, but ANA profile may show some positivity. Ultrasound is to look for any infiltrating lesions. What is ultrasound finding?
Ultrasound, there is mild splenomegaly.
Few bilateral external iliac inguinal mesenteric nodes. So these all can occur in. Was he an atopic individual?
Yes, sir. He is atopic.
Then these patients can have granulomatous lymphadenitis, granulomatous hepatitis, and PUO, like presentation. So you need to again think of allergic angiitis granulomatosis with all these involvement. Lung may not be involved always. Next what?
Chest X-ray was very normal.
X-ray you need to see directly to look for any interstitial mottling. To look for, if it is there, it supports autoimmune disease like granulomatous angiitis. Then
the serology was negative. Was also negative.
So what was done later?
Later, he was suggested bone marrow. They were not willing to do bone marrow, sir, but they got discharged 2 days back and kept under OPD follow-up.
Okay. So now what all we need to do in this patient? Don't just think that the clinical diagnosis that you got, one of them is there. Which one will you favor? You have to look for a granulomatous hepatitis of autoimmune etiology. They can present as fever. These are especially common in people who are having atopic tendencies. Atopic allergic conjunctivitis, they go together.
Yes.
And you do not know what has happened. He didn't come back.
No, sir. During this week, they will come in the OPD after 2 days, sir.
So anyway, get an ANA profile. Then sometimes you may get sometimes you may get no investigations positive in such patients. When you are ruled out reasonably all infections, you may have to initiate treatment on the lines of autoimmune disease. That's what is needed in these kind of patients. You may not get any of the autoimmune markers positive rarely, but you have to rule out all the other common conditions. Now, infections. Brucella serology was done.
No, sir. Brucella serology was not done.
Maybe that may be done. Anyway, tuberculosis, X-ray chest has to be reviewed for miliary mottling once more, directly reviewed. But clubbing you cannot explain. Brucellosis also, you cannot explain all this. Echo was done from where?
From medical college only, sir. From here,
Okay.
2 days
You
back.
specifically told them to look for vegetations,
Yes, sir. Told them to look for it. There was no patients.
Sometimes vegetations you can miss. Because small vegetations may not be picked up by echocardiography. That's why sometimes they may recommend transesophageal echocardiography. Or suppose your suspicion of infected endocarditis is very strong, you don't have no other possibility. Either you start treatment, or along with that, you may look for vegetations by another modified method, transesophageal echocardiography. But don't delay the treatment if your suspicion of endocarditis is very strong. Low virulent organisms may not be grown in culture also. So in fever, clubbing, that has to be considered. And chronic subacute endocarditis means chronic. They can have autoimmune phenomena, including liver or renal involvement. So we need to still keep subacute endocarditis with immune manifestations as the first clinical possibility. Then autoimmune disease with the granulomatous hepatitis. These two should be sustained even at this stage. So what you will do? You can start him on an antibiotic. That is why there was some initial improvement in ceftriaxone.
Yes, sir. They
So,
improved after 7 days of IV antibiotics.
so actually you have to give antibiotics for 2 weeks. And then if the fever sustains, and if you have no other proof, and a profile may be repeated, and then start treatment down the lines of autoimmune disease. That is what is needed. Anyway, that is beyond the scope of a family practice setup, but you should think of the possibilities. You should not miss infected endocarditis. You should not miss chronic liver disease clinically. Very sure there was no fam hepatomegaly.
No, sir. There was no hepatomegaly. No
Okay.
fam-
Okay. Any other points, others? There are some questions, no? Do not think of obstructive jaundice in the absence of jaundice. Antibiotics, you can give antibiotics ceftriaxone as you use for infected endocarditis, and gram-positive cover with one penicillin or vancomycin. Cloxacillin or ampicillin or vancomycin itself may be used if the suspicion is very strong. So start on antibiotic while you keep the patient under observation. But give what else? You have to give B12, folic acid, vitamin D. These nutritional deficiencies are also equally important in the manifestations of the disease. Any other any other question? Any questions in the chat box? Any other questions?
Sir, there is a question in the chat box, sir.
What about the throbbing headache? That headache could be a vascular headache in anyone who is in an atopic individual. That allergic rhinitis is enough to produce headache. Irrespective of the cause, they may come with headache as an additional symptom, Do not think of a CNS problem in this patient unless you have neck stiffness or PGS or raised ICT or something to suggest a CNS involvement. At this point, you don't have any. Is the headache a raised ICT or not? That question is important.
No, the headache would relieve
How do you know that headache is not raised ICT?
because
If
the
it
headache
is,
would relieve sleeping.
if it is relieved after sleep, it is not at all a raised ICT. Is that clear? And if he has rhinitis, that will suggest that it could be due to allergic rhinitis triggering a vascular headache. Vomiting is either due to the gastritis or you need to consider hypotension here. In a patient with this kind of presentations, the vomiting may be part of hypotension because sodium is also on the lower side, potassium is low. So keep that in mind. But that is not the primary diagnosis. Primary diagnosis is autoimmune or chronic infection. Both can produce hypotension. But gastritis is common to all these conditions. And one of the reasons for his gastritis is butyl folate deficiency. Because they have mucosal damage due to the butyl folate deficiency, and that is the commonest predisposing cause for the gastritis in such patients. Any other? When you are sending him home, you may start on at least on oral antibiotic. Ideally, IV antibiotic because one of the differential diagnoses is subacute endocarditis with immune manifestations. Subacute endocarditis can have extra cardiac manifestations. You may get immune phenomena involving liver, kidneys, lungs, and that possibility still remains. Anything else? Any other questions? Otherwise,
Any other doubts?
this patient, a planned observation and review is one of the most important investigations. So you have to review him, but you must have an action plan. After giving an action plan, you can ask him for review. Rather than sending him home, just ask to review because he has a problem. And based on the most likely problem, you have to start an action also. Vomiting is multifactorial here, either gastritis or butyl deficiency, including and hypotension. Hypotension can also have vomiting. There was no lymphadenopathy. Somebody was asking.
No lymphadenopathy.
Tuberculoma you cannot consider because tuberculoma means brain. So the headache does not suggest a CNS involvement, but and tuberculosis may not come with fever and headache. If you have some lesions in the brain, again you may have to think of autoimmune diseases, granulomatosis disease involving the brain. But tuberculosis, by chance, the headache is persisting and the headache is not relieved by sleep, you may get a CT or MRI. And there is no neck stiffness. Any other possibility? Eye signs for thyrotoxicosis you have to look for, but that is seen in Graves' disease. Clinically, it is not Graves' disease. There are several reasons for absence of Graves' disease because pulse volume is normal, tachycardia is not there. Graves' disease can have bruit over the thyroid, tremor, the pulse rate also. There are no features of Graves' disease clinically. Any other possibility?
Another question in the chat box, sir.
What are the follow-up investigations? That's what I said. you may have to repeat the lefty, get a CRP repeated, and I will do an ANA profile also. And then, as a last resort, sometimes a liver biopsy also. Because there are evidence of involvement of the liver, you may get some evidence of granulomatous hepatitis. And if the thought of granulomatous hepatitis due to allergic anginitis granulomatous becomes more strong based on clinical evaluation, P anga, C anga maybe asked for, sometimes you get it positive. Anga positive vasculitis can present like this. With the liver involvement, you can get clubbing also. Any other possibility? Echo for subacute endocarditis, that is why you may have to repeat. Because urine routine, did you get any microscopic hematuria?
No, sir.
No. If there is,
Examination was normal.
if there is microscopic hematuria, still the possibility of endocarditis comes up. So it's a problem case, you need to have an action plan. Anything else?
Any further questions? Sir, I think there is no further questions from the PG, sir.
Okay,
Shall we wind up the session, sir?
definitely. Thank you. Thank you for the. I was not able to even speak properly because of the nasal congestion and bronchitis. So hope it was useful.
Sir, myself, Dr. Suchitra. I am the PG coordinator of Spice Road Kerala chapter. So for us, it's a great privilege to have you here for this evening, sir. I think the art of case discussion, that's rarely we get in our sessions. So thank you for your statements. Not considering your health issue, you came here and gave a very good session for the PGs. And on behalf of the Spice Road Kerala chapter and the entire PGs who participated today's session, thank you, sir.
Thank you all. Good night.
And Arifa, it was a great presentation, and thank you for this wonderful session for tonight. Thank you, everyone, for
Arifa
participating.
presented it very well. Arifa presented the case very well.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.